The second presentation by Dr. Abhishek, cataract surgery in pre-existing CRVO.
Dr. Abhishek Desai is working at Jalna and a proficient vitreoretina surgeon there.
Where my present? Yeah. Thank you, everyone. Thank you for the kind introduction. I would like to thank Team Scientific Committee and all the panelists for giving me this opportunity. Today, I'll be speaking on approaching a case of cataract with pre-existing CRVO. As we all know, CRVO arises due to thrombosis at the lamina cribrosa, and common risk factors include diabetes, hypertension, hypercoagulable states, and old age. Patient presents with acute decline in central vision, which is mainly due to macular edema and ischemia. Broadly, it is categorized into less severe non-ischemic variant and more severe ischemic variant because it is associated with anterior segment neovascularization and risk of neovascular glaucoma. Based on the recommendations of many landmark clinical trials, it has been advised that anti-VEGF monotherapy is considered as a first choice for these cases for macular edemas associated with CRVO over the corticosteroids due to associated other risk factors. And dense PRP is indicated in presence of neovascularization, mainly neovascularization iris. Now, approaching such cases of cataract with pre-existing CRVO, we should be thorough with our history-taking, ocular examination, appropriate retinal imaging whenever necessary, and keeping the primary care physician and retina colleague in the loop throughout the course is very crucial. Now, as we all know, apart from regular history, we should specifically ask for history related to the past episode of any thromboembolic events or any other positive systemic comorbidities. And in ocular part, we should ask whether they have received any injections, what are the number of injections and what kind of injections they have received. Is there any history of retinal photocoagulation, or what was the documented vision earlier? This is very important. And coming to the examination part, apart from our regular examination, we should specifically look for presence of RAPD, and in undilated pupil examination, we should look for neovascularization iris, neovascularization angles in association with the gradation of cataract and pupillary dilatation. In posterior segment, we should look for is there any active macular edema, ischemia, or neovascularization elsewhere present or not. Now, we all know the acute CRVO is easy to diagnose, but if patient doesn't give any history of, or if he is unaware of any CRVO episode in the past, how do we diagnose? So what are the signs or features that suggest or indicates that this eye had a CRVO earlier? So presence of venular tortuosity, deep retinal hemorrhages, especially in the temporal periphery, presence of disc collaterals, and presence or absence or signs of resolved CME, all these points towards the case of old CRVO. Now, if cataract is not so dense and view is permissible, then one should go for this specific test, or rather it should be mandatory, like fundus photography. It helps to document the progression of the disease. OCT is an excellent, OCTA is an excellent non-invasive tool which gives us an idea whether there is active macular edema or macular ischemia present at this moment, and it also helps to monitor the treatment response successively. FFA gives us idea about whether how much is the capillary non-perfusion, and it also helps to distinguish between the collaterals and the neovascularization elsewhere. And if cataract is very dense and view is not permissible, the B-scan or ultrasound is an excellent diagnostic tool which gives us idea about anatomical status of the posterior segment or retina to plan the cataract surgery. So with this history examination and diagnostic imaging, we will have a fair idea about the outcome of cataract surgery in these cases. That will help us the better counseling to have the realistic expectations of the patient. And that would also help to prevent unnecessary medico-legal implications and misunderstandings post-operatively. In such cases, it is better to wait for macular edema to resolve completely and to remain so without treatment for at least 2 to 3 months before planning the cataract surgery. Also, it is of paramount importance to have uneventful cataract surgery, especially to avoid PCR, as this would increase the VGF load in the anterior segment and hastens the process of anterior segment neovascularization. As with any other posterior segment pathologies, monofocal hydrophobic IOLs are preferred over multifocals and silicone IOLs because that may hinder the posterior segment visualization later if any posterior segment intervention is required. A close follow-up and treatment when indicated for at least 2 years is very crucial to reduce the risk of losing visual acuity in such cases. These cases are more prone for pseudophakic CME post-operatively, so it is better to start them earlier on topical NSAIDs for the resolution of CME and for its treatment over no treatment. Now, having seen the basic knowledge how to go about this case, let's see a few case scenarios in short. Suppose there is a case of acute CRVO with CME and cataract. What should we do? We should continue anti-VEGF, wait for the macular edema to resolve, and then plan the cataract surgery after proper discussion with the patient and patient's primary care physician. Now, suppose there is a cataract and old CRVO, we do imaging, there is no edema, then you can plan cataract surgery immediately. But to look post-operatively specifically for the anterior segment neovascularization to prevent risk of neovascular glaucoma or to diagnose it earlier. Now, if there is a dense cataract, no fundus view, but there is a documented record of old CRVO, after proper anterior segment evaluation and posterior segment evaluation, if posterior segment is normal over B-scan, plan cataract surgery, have a thorough examination and imaging later post-operatively, or have a retina colleague's opinion. Now, somehow we face similar such cases. Sometimes the edema doesn't go no matter what you do. Then what to do in such cases? There is a cataract and non-resolving CME. For example, in this case, this patient presented with acute CRVO with edema. Initially, it responded well with the anti-VEGF. But after a few days, again the edema rebound, there was a rebound macular edema, and which was not going easily. In such cases, continue the anti-VEGF and follow treat and extend regime over the PRN regime, and you can plan cataract surgery if cataract is very significant under anti-VEGF cover. So the predictors of good visual outcome in such cases is younger age at presentation, good baseline visual acuity, and intact subfoveal ellipsoid zone. All these points towards the good visual outcome. So while approaching these cases, our goals should be to improve and stabilize the visual function and vision-related quality of life, to detect timely and treat neovascular complications and macular edema, and to control the modifiable risk factors through direct communication and coordination with the patient's primary care physician to prevent similar risk in the other part of body and other eye. Thank you. Thank you for patient hearing. Thank you.
Nice presentation. One point is like you talked about giving anti-VEGF therapy to reduce the macular edema and doing cataract surgery. What about giving Ozurdex injection in such patients vis-a-vis anti-VEGF injection in such cases?
Sir, steroids, no matter, it does help in these cases. That also provide level 1 evidence. But anti-VEGFs are preferred over the steroids because the risk of glaucoma is less. And also, as per the documented evidence, VEGF is preferred over the steroids. If VEGF patient is not responding, as per American guidelines, we should inject 6 continuous injections before switching to any other injection or Ozurdex to have a steroid rescue before switching to other anti-VEGF. But in our setup, in our country, it is difficult to convince for 6 injections if it is not responding. So based on patient to patient, we need to decide whether what is best possible solution for that particular case. But yes, Ozurdex can also be given.
A good option.
Yeah.
Giving long-term
yes.
treatment.
But after 3 months, once its effect wanes off, there is a bad rebound edema is what I have seen.
What is your take on Dipender and Ashish?
See, steroids are definitely a good alternative in peri-operative
Yes.
period
Yes.
for all these macular edema cases. But you rightly pointed out in Cefodex study, the risk of steroid-induced ocular hypertension was highest in vascular occlusion group,
Yes, sir.
almost 35%.
Yes, sir.
Compared to DME, it was hardly 20%,
Yes, sir.
and uveitis was in between.
Yes, sir.
So yes, I would also be little hesitant to give DEXA to all CRVO patients before cataract.
Yes, sir.
But if they are with you for some time, you can do a steroid challenge test. You can put them on steroid drops and maybe give couple of anti-VEGF injections. And during that period, you judge their steroid responsiveness. And when you are planning cataract, then if they are non-responders, then you can still use DEXA implant.
Yes.
But you rightly said, overall, I think this whole topic needs mainly management of CRVO like we
Yes,
do, and
sir.
it's not a good disease for anybody to
Yes,
have. We
yes,
all know
sir.
that.
Yeah.
So, but we should not also be depriving them of cataract,
Yeah.
because many of them do get stabilized either because of collaterals, and you take care of ischemia.
Yes, sir.
Depending on your threshold to bring PRP,
Yes, sir.
do a proper laser, and then we should operate them. But of
Yeah.
course, just like we do for PDR cases.
Yeah. In that case, that's why the pre-op counseling is very important, to have realistic
Only
expectations.
thing which I am little much more careful in these cases is not to miss an NVI,
Yeah, that is
because
true.
intraoperative
Yes.
and then post-operative
Yeah.
problems can be
Yeah.
even if you have to do a intense PRP, if you see even if you have slightest doubt of NVI, do an aggressive PRP
Yes.
before cataract,
Yeah.
because they can suddenly change gears.
Yeah, but sometimes if cataract is dense, view is not possible, you can plan PRP immediate post-operative period also. Yes.
Correct.
Yeah.
Ashish and Kenshuk, anything they want to
Thank you.
point out?
Sir, I will be taking some points in the next mic.
Okay.
Okay. Thank you. Thank you, everyone.
Say that if the approach is quite good, you get 2 or 3 anti-VEGFs and then probably aim for either an orthodox or a cataract surgery.
But sir, in perioperative period, giving steroid implant is also increasing the risk of infection post-operative period. Because I have had one end of when I planned DME and cataract surgery plus Ozurdex in the same sitting in table. So from that episode, I am little hesitant to inject steroid implant
Normally
during
we give
surgery.
2 weeks
So
prior
Ozurdex,
to-
when do you give Ozurdex? Seeing the visual acuity or the thickness on OCT?
Uh, Basically, I would never prefer Ozurdex over anti-VEGF. I'll always give anti-VEGF try over Ozurdex. Unless and until if it is not responding, then only I will think of giving Ozurdex. Only if that PC is intact, patient is pseudophakic and no history of glaucoma and cupping in the disc. PC intact should be there. In YAC patient also, I would not prefer Ozurdex.
Right. Thank you.